We are going live in 3, 2, 1. So, good evening and welcome to this another episode of Wednesday Musings with Dr. Borate sir. And today we are going to discuss a very, very important topic regarding ethical consideration in our clinical practices. I think these are the issues that we need to face and resolve almost every day of our clinical practice. So, we'd love to hear the insights that Borate sir has over this issue. I'd like to invite Dr. Tarang, our convener for the meeting today. Over to you, Tarang, for further questions.
Yes. Yeah. So, hello everyone. Thank you, sir, for having me. And so, ethical dilemmas in medical practice, we've been recently hearing this term a lot. And probably because of many doctors landing up in consumer courts or the ever-growing pharma industry, or probably the ever-evolving technology in medical field. And ethical dilemmas essentially, as far as my limited knowledge, is when you are having one or more options and you have to choose between a lesser ethically sound option. And how do you justify what decision you make? And there are so many instances in medical field. For example, the young people they know that advertising yourself as a medical practitioner is not ethical. It's probably not even legal. But then at the same time, they are seeing on radios and wherever possible, the hospitals being marketed and advertised like anything. So what is the difference between what are the loopholes between these advertisements? What are the technicalities we'll be going through today? So Borate sir, over to you, sir.
Yeah, let me begin by saying that the code of conduct and what is considered to be correct behavior by all practicing doctors in India has been codified in the Code of Conduct for Doctors by the Medical Council of India, now called as the National Medical Council. Now, the problem in the past was not so much simply because, say, when I was a resident or when I started my practice, whatever was written in the Code of Conduct was scrupulously being practiced by almost all the doctors in the big cities that I knew of, So there was no discord between what was supposed to be done by doctors and what doctors were doing. But gradually, these things changed because of various reasons, but mainly the competition and the need to promote oneself and keeping the ethical issues or bypassing them or ignoring them and so on. And that is why the resident of today or the young doctor of today has this problem. He has to he's supposed to abide by a code of conduct which doesn't allow him to do almost anything by way of promoting himself. Whereas he sees a lot of promotion being done by everybody around him. So we will try to understand some of the things that, some of the provisions that make it possible. And I think it will become clear as we go along. I have tried to divide the problems that we face into certain groups or issues which are not necessarily related to the code of conduct. In another session, we are going to discuss the code of conduct in the organized format that it is presented. So let's begin by what happens if somebody lodges a complaint against a doctor. So normally in India, this complaint is lodged either with the consumer courts or with the civil courts. The third option is that the doctor can complain to the medical council, which means usually the complaints are accepted by state medical council on behalf of the Medical Council of India. So he will complain to the State Council, which may have a branch or the nearest branch where he wants to. So in whichever case this happens, the doctor is supposed to, if he receives a letter from any patient with a complaint and asking him to respond to it, then he's supposed to respond to it. And he's supposed to, give his explanation, whatever it is, and not just wait for a legal process to begin. So this is one of the guidelines that we should be aware of. The second thing is that we have always discussed this often, is how to communicate with our patients. And we have already talked that doctors usually don't allow patients to talk. They interrupt them and they just get on to what information they need to get out of the patient to decide what is wrong with him and so on. They are not willing, or they are either impatient, or they demonstrate their impatience by interrupting conversations, which is not a good idea. And the other problem is that most of our orthopedic surgeons are very well trained in technology, in doing operations, but they are uh, they get very limited training on how to, interact and communicate and, be nice to their patients. In fact, this is one of the problems that we will face as we discuss this issue further. Now, this is the next thing is translation. Now, this is not so much of a problem for us in, say, where we practice today, because most of our patients, we are in Maharashtra, for example. So most of our patients speak the local language, and most of our doctors speak the local language. But as the world becomes more integrated, like in Pune itself, you have patients from every state in the country. And many of the older relatives of those patients may not be able to speak the local language or English. So this problem is going to come more and more. And we should know what is the guideline. One guideline is very clear that we should not use the family member as a translator. Now, you might, in practice, it is usually the family member who acts as a translator. So if the patient is the mother of somebody and she can't speak the local language, then the son acts as the interpreter and so on. Now, this is okay if the patient agrees. You might ask why this is not a good idea. It's not a good idea because there are medical legal issues and there may be some confidential information of patients that may not be appropriate to be communicated and discussed through a family member. So this is one important reason why family members are not preferred as communicators.
Yes. So,
The other thing,
before
of
you
course,
proceed,
yeah,
before we proceed, because we are in that groove of translation, I practice in a city called Solapur,
yeah,
where it is the border for Andhra Pradesh and Karnataka. So we get patients from peripheral regions who speak Kannada and Telugu. So it becomes a problem, but I have my staff who can translate. Now, on
yeah,
the
okay,
point of family members being used as translators, it is a very valid point. Because in pediatric orthopedics, when I see a patient of club foot, the patient and the mother is accompanied by the mother-in-law.
yeah,
And mother-in-law, somewhere, the uneducated people, somewhere they want the blame to be taken, the blame to be put on the mother. That is,
or
they are
her
talking
family,
about.
or her
Yeah, the family. Yeah. So if I am translating something and if I'm telling them the actual cause that it could be idiopathic and the genetically it has nothing got to do with the mother, you are not sure what they can transfer to translate it to the family. So that is a very valid point in not having a family member
Yes.
as translator. Yeah, sir, you can.
See, the other thing is that we commonly use some of our staff member who is familiar with the language as a translator. And this normally is okay if there is no other option. But what is recommended nowadays is that you use a professional translator, somebody who is qualified as a translator, and identify such persons and make use of their services if required. This is the official guideline, and this is the medical legal recommendation. In our country, in our practices, it still may not be that important. But I just put this in because I thought we should all be aware, you know. Another issue that always comes in our lives is when we have to transfer a patient from our care to another hospital. Now, there is also an issue because most of the times the patient may not be in a condition, patient may have deteriorated, a patient requires to be transferred because the kind of care that he requires is not available in that hospital. So, this important guidelines is that you must first stabilize the patient if at all it is possible. You must decide if the risk for transfer is less than the risk of keeping the patient. And the accepting hospital and center must know of and accept the patient. So it shouldn't be that you're taking a serious patient somewhere, and when you reach there, the hospital refuses to accept the patient. Not a, you will be in a very awkward situation. What I have always practiced is that a resident doctor or a medical doctor should accompany the patient in the ambulance uh, at any cost, you know, because in the unlikely but often possible event of the patient dying during transfer, if there is no medical attendant, it is considered very, very negatively by the patient and also by the law. Now, if there is a doctor and the doctor is actually not even capable of doing real, resuscitation, it doesn't matter as long as the relatives and everybody knows that there was a medical qualified person accompanying the patient. This many times is not followed or sometimes even difficult to follow, but this is important. And there are some other issues regarding transfer which we will discuss when we talk of some examples. Now, there is another issue called diversity. That means sometimes we get patients who are, female and unaccompanied. We have patients who come from other cultures with whom we are not familiar, or we may have a negative opinion of that culture or that race or that ethnicity and so on. So, what the law and what the profession expects us is that we should not discriminate, even if the person that we are treating is not somebody from a race that we are particularly comfortable with or so on. It should not affect our uh, relationship and affect our treatment. And especially, it should not affect the quality of care. Again, this we will discuss a little more with examples. Uh, Another issue that sometimes comes, and I've seen it often happening in hospitals, is that the type of insurance that the patient has sometimes, uh, affects the attitude of the hospital in general and the staff, and sometimes even the treating physicians. Because it is true that if patients carry a little more comprehensive or a little more expensive insurance policies, which enables them to have a special room or deluxe room and so on, the doctor and the hospital are likely to be paid better than if the patient is not having such a expensive policy. But we have to be very clear in our minds that this should not uh, affect the quality of care that we are giving to our patients. I know that it is something that most of us usually are aware of and always keep in mind, but there is another positive side to it. If as a doctor you give very good care to your patients who are not special room, then they will tell all the other patients about you, and you will get more referrals because the people who are in the general ward will know that this doctor is particularly good and concerned and interested in patients even who are in general ward. So that is why I feel it is also in our interest to not let the type of insurance affect uh, our behavior with the patient. Sometimes we have some devices that we have helped to develop and we are getting some royalties. So it is necessary to tell the patient that this device was developed by you and you are involved. Normally, patients will be more than happy if they know that there is something that is going to be used which the doctor himself has developed. So I don't think in our country that's so much of a policy. We are more than happy to disclose this. We come to the important problem of relationship with the pharma and the implant or other health related industries. Now, I must tell you here that the Medical Council of India does not allow any benefits for doctors um, to be accepted. They have recently made some amendments in the year 2016, and mm, I will tell you about it. The important amendment that affects uh, us is that all associations, like doctors associations, Indian Medical Association, Indian Orthopaedic Association, all associations have been exempted from the provisions of code of conduct. So, in other words, the associations can take benefit from or sponsorships from pharma and anybody uh, in the conduct of their educational and other activities. Now, I am just going to tell you a few things which are now accepted in the United States and being practiced. So, one thing that they are saying and practicing is that as doctors or as teachers or as professionals, they are allowing doctors to accept travel, hospitality, uh, to attend a seminar or conference or anything which is non-CME in nature. So anything that you're attending which is non-CME, it's okay for you to accept the hospitality. For a CME, it is okay if you accept the registration charges, but not the hotel stay for you and your spouse and other things. So there is a distinction between CME and non-CME. The other thing is that if you are having some sponsorship for something that you're doing, either in the way of some operations or something, you should tell this to your patients and your institution and be open and transparent about any sponsorship or any subsidy that you're getting to try out some treatment or to document and use some treatment for research. They in America now are saying that you should not accept a personal gift of more than $100. In India, they are saying that it should not be more than 1,000 rupees. So it's less. Uh, they're also saying that you cannot accept direct kickback from any hospital or from any industry for doing something that you're supposed to do as a professional, uh, uh, and so on. You also are expected to not refer patients to hospitals where you have a monetary interest and where the patient is being treated by somebody else and you are going to get a kind of kickback for sending the patient there, or you're going to make a monetary benefit. Again, here, if you disclose this fact to the patient and the patient is okay with it, then I don't think it's such a big problem. Um, so I've just briefly covered the relationship with pharma and other industries.
Yeah, so just to summarize, very
Yeah.
important points. There's a difference between the CME and non-CME events.
Yeah.
And attending a non-CME event is still fine. And a sponsorship of the registration is also fine, but the stay and the dinners should not be accepted. Presently, the USA has a direct gift not worth than $100 as per the guidelines of the USA, and in India it is evaluated at 1,000 rupees. No direct kickbacks, and very important for our doctors, no referring the patients to hospitals in which you have monetary benefits, and where the operating surgeon is a different person altogether. Right.
Yeah, coming to the issue of advertising,
Right.
This is now happening in a big way in India, particularly with the social media and hospitals and doctors having their own websites. So, as far as India is concerned, the Medical Council uh, has clearly stated that doctors are not allowed to advertise in any form whatsoever. They have certain provisions where if they're starting a practice, they can make an announcement in the newspapers or in public media. If they're shifting their address from one clinic to another clinic, or if they have qualified in something and which they're starting something which they were not doing before, and so on. So they have given some provisions under which you can inform the public through an advertisement or in the newspapers and so on, announcements and so on. But other than that, the individual doctors are not allowed to advertise. Now, the medical association has not specifically mentioned or addressed the issue of having your own personal website for informing patients about, the various conditions that exist in your specialty, and giving them access to information to learn about how these things are treated and so on and so forth. I am not sure how this is will be addressed at a practical level. Till somebody lodges a complaint against a specific doctor for advertising, either as a patient or as a colleague or anybody, uh, the medical council is not going to go and do policing of all doctors and how they are conducting themselves. Reason for which a large number of things that are happening today, which are not being regulated. So it is up to an individual doctor how he wishes to, uh, you know, um, interpret how he should, what is permitted and what is not. But the wording is very clear and it is not permitted. Now, the only exception is that hospitals have been advertising because the Medical Council Code of Conduct doesn't really cover hospitals. So that is why the hospitals are taking advantage of this. And they are advertising as websites and on social media and in newspapers and so on. And but remember this, that if somebody complains against a hospital, it has happened in the last few years that the medical council of that state has taken strict action and strict view and actually, taken action against hospitals. So the medical council doesn't really allow any hospital to use the name of any doctor and under the guise of promoting the facilities at the hospital to advertise about the doctor that is working there. But at a practical level, since this is not happening regularly, or it is not, there is no policing mechanism with the medical councils. So that's why you are seeing a lot of these things happening. What we need to very, very carefully avoid is to not give wrong information about ourselves, even if one does put out some information. For example, if there is no degree in joint replacement, say. There might be a fellowship, but there is no MS orthopedic into bracket joint replacement. There's nothing like that. So there are no super specialities or subspecialties which are offering postgraduate degrees. And so if you were to put that as a qualification, then obviously it is overstating something that you don't possess. And you are trying to just use some credential that you have to make the public believe that you have something that you actually do not have. So that is something that should be avoided. Then using words to describe oneself as world renowned and so on is also not supposed to be in proper. Um, and promising painless surgery, promising bloodless surgery, promising cure, all these things should be avoided and should be carefully worded. Even if one wants to say that the type of technique that one is using reduces the blood loss to a very remarkable extent rather than saying bloodless, or whatever treatment you are using has got a recurrence rate which is very, very low, whatever. So these are some of the things that one should avoid, even if one has to describe oneself or put something out in the public domain, either on your website or hospital website or some other social media. So I think we'll go to some examples which are quite interesting.
Yes, sir. Before going to the examples, sir, I would like to just summarize because these are very valid and important points you have made. So no, as far as the advertisement is concerned, no individual doctor is allowed to advertise. If he or has to do it, it has to be either if he's starting a new practice, if he is shifting his place of practice, or probably he's upgrading his services and starting a new faculty in his setup. And that too, let's not use the word advertise. He can inform it via newspapers and social medias and websites. And the hospital can advertise, but then again, if there is a written complaint, strict decision will be disciplinary action will be taken by the state medical based on the examples in the past. And very importantly, no wrong information or misguiding informations, like you mentioned the examples, painless and bloodless surgeries and cure of the disease and registered and certified joint replacement surgeon. Such wrong and misguided information should not be used in your resume or your advertisement. Fine, sir. Wonderful. So,
so I'm going to skip the first two examples which relate to translation and to advertising. We'll go to the third example, which relates to transferring of a patient. Okay. So there are 5 statements made, and one of those statements is a must in legal terms while transferring the patient. So the 5 options are that insurance level must be discussed with the accepting hospital. Second, all appropriate laboratory workup must be completed. Third, the patient must be medically stable for transfer. Fourth, the existing facility must have resources to properly treat the patient, and the cost of transportation should be within reason. So, which is absolutely required? No, the existing facility must not have resources. So the hospital which is transferring because they do not have the facilities and equipment to treat the problem that the patient has. So out of these 5, which is the most important or which is absolutely necessary to transfer a patient? So the answer is that all the other things are not important, but the existing hospital must have a justification for the transfer. And that justification is only that it does not have the equipment or facilities to treat the problem that the patient has either come with when he came to the hospital to begin with, or has developed during his stay, which is a relatively rare problem, and that is why it is necessary for him to transfer. So this is the important legal issue. The other thing that some research has shown is that children are transferred more often than adults because hospitals which have limited facilities are afraid to treat children who are seriously ill and have problems. Secondly, a lot of transfers seem to be happening at night, which again is not really explained, but that's one of the findings. And patients who do not have proper insurance are also subjected to transfers, and especially those patients who have uh, inadequate insurance but who have many comorbidities. So they are the ones that are most likely to be transferred. This is then going to the next problem is a patient who underwent a joint replacement surgery and then went home without any problem. I mean, and then 6 weeks later, the patient has come to the emergency room with purulent drainage and, fever and so on. Now, as a doctor, you see the patient and advise treatment, whatever it is. And the patient becomes very angry, and uh, when it is told that he's going to require surgery and debridement and whatever, he just goes away saying, I don't want your treatment. And then you find that the patient has filed a formal complaint accusing you of malpractice in a consumer court. So, which of the following statements are true? One is that malpractice investigations are governed by Consumer Act. A surgeon's license is automatically suspended when a complaint is made till the complaint is resolved. The surgeon should provide a written response to the investigating agency. The surgeon should contact the patient's lawyer directly to negotiate a settlement. And lastly, the surgeons are required to retain a lawyer to address any complaints against them. So, amongst these five, one statement is important, and all the others are not uh, applicable or not appropriate in this situation. So we should know, for example, that the only important thing here is that whenever a complaint is made, the surgeon is supposed to respond in writing and give whatever his side of the story is. A surgeon doesn't need to necessarily retain a lawyer. The surgeon has no requirement to contact the patient's lawyer or have any discussions whatsoever with that person. And the whatever is the provisions of the law, the surgeon need not worry about it as long as he has taken adequate care and done all the proper things. And there is the license suspension has not been in the purview of any consumer or legal act. Only the medical council can suspend or cancel a license because they are the issuing authority. We should know this, and we should not be afraid of whatever else may be said or discussed during any such incidents or any such things that happen. Now, I'm going to skip the issue about royalties for new devices that doctor may have developed, other than saying that you should not implant a device without telling the patient that you have developed it and so on, and that you are an interested party. So you declare your interest so that there is no accusation later of a conflict of interest. And also you have to follow whatever are the legal provisions in relation to charges and so on. So the only thing here to remember is transparency and full disclosure. There's nothing wrong in using something that you have developed. There's nothing wrong in accepting charges and putting charges, whatever are applicable. It is permitted by the existing legal and insurance framework. Um, Now, when patients are surveyed regarding orthopedic surgeons, which are the ratings that are given highest? Are they about medical knowledge, about their social skills, about their technical skills, about their communication skills, or empathy? And the answer, not surprisingly, is that most patients are very impressed and admire the technical skills of their orthopedic doctors, but they are not often very happy with the communication and the empathy that is displayed by orthopedic doctors.
Right. So we need to improve on the communication skills a lot. Orthopedic.
Yeah.
Yes.
Yeah. So there are certain things that are relating to what doctors are supposed to do when dealing with industry and pharma. So one is that you decline gifts that are more than $100 unless they are medical textbooks or patient educational material. You should disclose to the patient any financial arrangement with industry that relates to the treatment. One should not accept any financial inducement from industry for utilizing a particular implant. Um, and if a particular implant has been made available to you for treating patients at a less cost, then you should make sure that the patient is aware of it and that you are not uh, charging the patient anything more than what you are supposed to charge as per the understanding with the supplier. Um, and you are allowed to, as we already discussed, you're allowed to attend any non-CME courses or conferences and accept hospitality, travel, and registration costs for that. So again, there are issues regarding whether we should accept travel and hotels, whether we should accept um, consultation agreements between with companies for evaluation of a particular implant or a particular. So there are certain research guidelines which we have to follow, which normally uh, are the same as whatever is legally uh, expected from uh, uh, the doctor. This important thing that I need to mention as a takeaway is that all of us or many doctors will be asked to be involved in research, find out whether a particular treatment or whether a particular implant or a particular type of um, equipment is good or better than the existing or the other thing. See, doing research is our reason for being doctors. Is our raison d'etre, as we say. But we must remember that we must use that information in an unbiased manner, and we should be truthful to the conclusions that we get based on what we have studied. So, whatever data we have, we should not manipulate that data um, to favor the requirements of a particular type of implant or manufacturer, and so that the opinion regarding that is different from what it should actually be. So we must be very careful, and that is why it is very important. I mean, I have always believed that one reason that one should not accept any inducements from anybody is that then one is free to do the right thing. One doesn't have any obligation, one doesn't feel any social or moral pressure to unnecessarily prescribe something that is not necessary and do something that is not needed and not in the interest of the patient. So the best policy is to avoid getting into any sponsorships unless they are for unbiased research and unless they are trying to address an issue which you anyway are interested in finding out, because we are always looking at what is the best way of treating something, and if there are more than one ways of treating, and one of the ways is a more recent technique which needs more data, which needs more time, we need to more know more before we can say whether it's as good as the previous. So those are things that we are always going to be interested in, and it is our duty, in fact, to see and forward this through research.
Absolutely, sir.
Yeah.
So, very nicely put forward with all the examples regarding the transfer of the patient, regarding if the patient files a complaint, and the qualities of the orthopedic surgeon, which are uh, uh, remarkable in a study which you mentioned, where we need to improve on the communication and empathy. Rather, we are scoring good on the technical skills, but we need to improve on that. And the professionalism relating to the interaction with the industry. Very valid points, important points. Not to accept gifts over $100 unless they are textbooks or educational material, and you have to disclose all these financial arrangements with the industry to the patient. And no direct kickbacks, like previously also it was mentioned. And uh, then again, there was this example we spoke about. um the advertisement also we spoke. And yes, so in the first half we introduced a few terms regarding the ethical dilemmas in our medical practice, and then very nicely with examples sir has explained each and everything.
See, I'd like to end just by saying something. That is that, when we see around us, our senior colleagues and our colleagues who are more successful or who are better known and prominent, we will see a spectrum of how they conduct themselves. We will see some of our colleagues blatantly advertising themselves, blatantly using every opportunity that they can to project themselves, and doing everything that is should be avoided or should not be used in relation to whatever we just talked about. And you will see a spectrum of some others at the other side who are extremely scrupulous and very careful about how they conduct themselves. So it is necessary for each one of us to do what we think is right and also what we are comfortable with. Because you are a very conscientious and a very conscientious and a very honest and straightforward person. Just because you see another colleague of yours doing things which you are not, comfortable doing, you shouldn't do that, because you will not be comfortable and you will not be able to do it also. So at the end of the day, one should follow your own instincts, your own heart, and your own values. So whatever values you are comfortable with, whatever values that have been inculcated in you, and most values are inculcated in us uh, indirectly. We see how our parents behave, we see how our teachers behave, and we want to be like them. So how you will what will be your value system of each individual is different. So I advise all my students that do what you feel comfortable with. Do not uh, do what you think is necessary for you to do, which is conflicting with your values and making you unhappy. So in the long run, in the short run, you may keep feeling that, okay, I'm not as popular as I would be if I had done all these things. Uh, you have to only tell yourself that it may take a little longer. I may not ultimately become as popular as some of my other colleagues, but I will do only what I think is right or what I think I'm comfortable in doing. In the long run, you will never regret this attitude. So don't do something that you are not comfortable. And the guidelines are already there. The guidelines are applicable to anybody or everybody. But some people choose to, uh, stretch the provisions of those guidelines, do things which they know are going to be overlooked because, as I said, there is no real policing in our profession. And therefore, a lot of people uh, uh, tend to think that, just like we see today in the obedience of traffic laws, a lot of people don't seem to care about obeying the traffic laws because there is nobody who is there to implement the punishment if you break the law. So this is the only advice I give to all my students. So I'm ending with that here as well.
Sir, no, sir, very excellent advice. Do what you are comfortable with when you are facing an ethical dilemma, obviously within the guidelines, and so that in the longer run you are facing less guilt or probably no guilt. That's a wonderful advice on an ending note. Ashok, Shyam, sir, your views on today's talk.
I think it covered exhaustively a lot of things. There is one query that I have been asked, and I also wonder many times. So, why there is a rule that we as doctors or surgeons cannot advertise ourselves and cannot advertise our skills? I mean, what is the ethical problem in that?
The answer to that is that this has come from the ancient times where it was considered to be inappropriate for certain professions to be commercial. They were dealing with, like the medical profession was dealing with human lives and human beings, and so you were supposed to depend on your patients to spread the word about how good you are. Um, I have no real answer to your question other than what I just said.
I always keep wondering, okay, there are rules and there are issues, but to display one's skill in ways that you feel are fair enough or good enough, why should not that not be allowed? I mean,
See, these are things that we will have to debate internally and keep representing to the authorities that decide our professional obligations, like the medical council. But I have another thought that will answer your question little differently. See, once you uh, say that the medical profession is no different from any other profession, and therefore we should be allowed to do what everybody else does.
no, that's what I intentionally did not say. I just
No,
focused on
because
on our profession. I'm not trying to compare with any other profession at all. Inherently
okay,
within our profession, what is the logic behind this rule? That's what I wanted to understand.
uh, yeah, but what I was saying is that there are many other things that relate to the medical profession and the legal profession, particularly, which relate to confidentiality.
No,
And they,
confidentiality, I agree. We cannot
yeah,
disclose anything about patients. We cannot
yeah,
disclose anything about.
and the other
But
thing is that
why can't I make a website and talk about myself in general? I mean,
Okay,
it's
so
like you
I
said,
think.
the
see the
guidelines do
problem.
not allow us to have
The
websites.
see the problem once you start saying that. You see, like if I'm a patient and I go to a website and I find that a doctor is making some claims that he has done 10,000 operations of joint replacement. I'm just saying. Now, as a patient, he has no way of verifying whether whatever is stated by somebody is correct or not.
So we watch television. We see
Great, but
advertisement
we
all
don't.
over the place.
Yeah, but
We
see,
have no way to verify anything that Colgate says or what
I
any brand says.
agree. I agree, but
Yes, sir, but these days, but
a patient puts his life in the hands of a doctor. You see, there is a
yes, sir.
difference, and he expects that he should have a reasonably level playing field of finding out whether somebody is better than the other person. So,
So that, I
advertising,
mean, keeping the information blackout will not level that field, I think.
So I
no,
think
no, agreed, but making certain amount of information available which can be verified or which can be compared is a
So
better way of
what I was implying is to a solution where the MCI or the body creates a web portal where our basic information is put up for patients to see. If you are
agreed.
not
So
allowing us to put that up, you can put the authority can put up our things and they can put up our CME details that we have attended so many things, we have attended this, and make it available to public to see.
see, the problem with all this is, really speaking, the reluctance of the doctors themselves, individually and as groups, to allow these things to happen. Because when you make this in a public sphere or in a verifiable manner, then you have to accept certain limitations and certain things that are comparable. Which doctor is willing to let his infection rate be displayed? For example, I'm just saying, or a hospital for that matter. So there are so many issues here which the medical profession itself is reluctant or unwilling. Whatever they might say in a public platform, in reality, they do not want to be compared. They are most unwilling to be compared
No,
to
no,
each
I'm
other.
not saying to compare or I'm not saying to put up basic information. Like you said, patients are searching for information. Where would they
No,
find it?
what you are saying, I will put it differently. You know, the associations or the medical councils should determine certain criteria for professional competence, for example. So if somebody is projecting himself to be a joint replacement surgeon, suppose I'm just saying, then the council or whatever should say that he should have done a certain number of these things independently and should have been so certified by the professional body that he represents. For example, I'm just saying. So now a mechanism exists where if you say that you have to do 100 of them before you can be considered as competent, or 500 or whatever. And then your association, like the Indian Orthopedic Association, has a mechanism saying that you have to submit all information, and once we verify it, we will certify that yes, you are competent to, as per the information we have received and verified. So there are some ways in which this can be done, and which will solve the problem of patient transparency in the way data is being put out in the public sphere.
Yes.
There is, I have an interesting thing about charges. One of the biggest problems that I see today amongst the public, and they have this complaint regarding all hospitals and all doctors. They say that, we do not know why some hospitals charge more and why some doctors charge more. And some doctors charge more when we do not understand that the amount of time they spend with us is relatively less, and so on. So they are saying that, all right, if I go to a hair cutting salon or if I go to have a cup of tea, I know that if I'm going to a five-star hotel, I have to pay more for the tea, and there are better facilities, and so I understand it. In the same way, I understand it in hospitals also to some extent. But why can't there be standardized charges for operations or standardized charges for whatever things, which the public should be made aware of? And this is one of the strong things that the consumer movement has been talking about. Um, we have another side, and there are many issues. It's too complex to discuss here. But we have to also understand that as technology advances, as social media advances, as the world becomes more knowledgeable about each other, and knowledge is no more confined to any particular manner in which it is put out before the public, these issues will come, and we will find solutions. Right now, we are groping, and maybe some of our colleagues are taking advantage as compared to others who are relatively less knowledgeable about the power of knowledge, or the power that the social media has of projecting information. But as we become more mature as a medium, and this is what Ashok has always been telling us, that there are aberrations in the freeing of knowledge and making it available to the world. But those aberrations are the beginning of, not the end. They are. We will mature.
We'll
We will
evolve
have.
from those aberrations.
We will evolve. Yes.
Yeah.
Yes.
So, sir, I'd just like to share something or add something. When a doctor is promoting himself, somewhere indirectly by doing, for example, he is saying that I've done n number of surgeries, and if he's using such misguiding terms like bloodless surgeries or painless surgeries, stitchless surgeries, laser surgeries, and it somewhere, I think, it ridicules the other practitioners. For example, I will share an example. One of my relatives had got done a bilateral knee replacement done.
Yeah.
And she was doing absolutely fine. But then all of a sudden, she came across so many advertisements of a particular center providing facilities of robotic joint replacement. Now, just going through those advertisements, she just happened to mention to me, I think I should have waited and got it done a robotic joint replacement. So my question to her was, what is the problem with you now? Are you suffering anything? Are you not satisfied with the surgery which you went through? So obviously she was doing very well. But then just because of the constant bombarding and a marketing gimmick which was used for a robotic joint replacement, she somewhere felt that I should have waited and got done a robotic knee replacement. theoretically we know there isn't great difference between robotic joint replacement and this thing, and usually manual joint replacement, and navigated and non-navigated. And secondly, when we are speaking about the television ads which we see on the television, I think there was a trend, or there was this new rule where there's a headline. If you have any complaints or concerns regarding this television or this product or advertisement, you can log on to soandso.com and give a complaint. Or even on social media like Facebook, we have this. If you want to report something, you can report an ad or something. And apparently they'll be taking action. I don't know how valid it is. But then similarly, if a doctor is putting up a website, I think he should be very well be allowed to do that. And there should be a portal or a medium where if the patient feels that there is some suspicious activity on this information or this website, he can definitely contact whoever, the MCI or the MOA or the IOA, and he can get confirmed. And we can just mention it somewhere, this information or website is certified by this so and so governing body. So that way we can allow, I feel so.
Interesting.
Yeah.
Oh, it's an area where work has to be done. We need not just blindly follow a rule that was laid down in antiquity. We just need to evolve with it and find ways and means on say evolving it or making some kind of adjustment to this.
If you ask me, the real dilemma that we face as professionals, as surgeons, is that when you want to become good at a certain procedure, there is a learning curve. And between doing your first operation and doing the required number of volume, and let's just assume that it is say 100. Now, during doing your first 100 operations, you will be learning a lot, and you will be, therefore, since you're learning, you will probably require more time to do the operation. You'll be probably encountering certain difficulties or doing some difficult variations of the condition. Now, through this journey, we should have a kind of roadmap of how the doctor should conduct himself. So, for example, if somebody is being trained in, say, joint replacement, it should say that the first 20 joint replacements should not be complicated. That means you shouldn't do them for malus valgus, fixed deformities, or you shouldn't do them for people who are comorbidities and elderly patients. But see, there should be some guidelines, and also there should be a standby senior colleague available in case any help is needed in terms of even not necessarily personal presence or washing up, but to ask certain queries, to find out certain issues and so on. And that should be incorporated into the practice itself. So then from say 20 to 50 or whatever, and so we have to do this on individual problems, and particularly in certain conditions where the volumes are going to grow now. You see, because if if you say CTEV, the amount of CTEV cases are likely to reduce rather than increase as population stabilize and so on. But joint replacements are going to go on increasing, and we need more doctors to do them, and we need doctors who are properly trained and also competent. So this is the issue that I think as professions we need to focus on rather than advertising. I mean, advertising is just a means that professionals are using to get ahead in the race, okay? To reach that critical mass of learning as quickly as possible, and not caring about what happens to the 100 patients that they operate or whatever it is. So rather than leaving everything to chance, as professionals, we should, and seniors who have reached done 500 should appoint themselves to take the responsibility of mentoring people during their learning period. That is not happening in an organized manner. It is happening in a very selective and a Guru Shishya manner. What do you say to that, Ashok?
I agree. The training part, etc., are difficult issues, and I think we have covered most of them in our Wednesday musing earlier parts.
I probably anyone who listens to our Wednesday musing, he'll change the code of conduct, which is going on since years, because we've been talking so extensively about
Yeah,
reforms. Yeah.
No, I think we are looking at issues with open minds. I
Yeah.
don't think we are, because there exists a code of conduct. We didn't create it, but we are also honest enough to discuss the difficulties that are faced with the code of conduct that exists, which is not necessarily keeping pace with the changing world that we live in, or the world that is constantly changing around us.
that's true.
Yeah.
So I think we have come to an end. Tarang, unmute yourself.
Yeah. So just the last 10 examples are very small example and a very funny example which I've faced, which I've seen. So an XYZ doctor, an orthopedic practitioner, when he extensively is giving intralesional steroids or intraarticular steroids for his patients. I heard about this, and he mentions that this is so and so point. That so and so or XYZ is his name. This is so and so point. Suppose the doctor's name is XYZ. This is XYZ point. Now, this is an example of desperate. This is blasphemous, and this is an example of desperate advertisement. And if there is some difference, or your technique is better than what the other world, the world is practicing, then you better publish it and show off or advertise your publication rather than just randomly giving intralesional and intrasteroid injections and promoting, telling the patients or your junior colleagues or your assistants that this point I have invented this point for so and so injection, and this is known as XYZ point, where there is which is not at all backed up by research or evidence. So this is that difference I wanted our viewers to know between desperate advertisement and evidence-based backed up research, which you can put up on your website if you really have some more in that field. Okay, that was a very extensive, exhaustive talk. Very reforming ideas discussed. We'll take a leave now.
Yeah,
Yes.
okay.